Okay, so let's talk about thyroid nodules. So again, these are more common in women. So almost any thyroid um, issue or disease is more common in women than men. Okay, and what thyroid nodules are just a collection of thyroid tissue, and most of them aren't cancerous, right? And often we can feel them in the neck, or someone will come in and say, I can feel a lump in my lower neck, and it ends up being a thyroid nodule. Okay. Um, and these are very commonly diagnosed with an ultrasound. So the thyroid gland can easily be seen with an ultrasound, and that's how we diagnose thyroid nodules and have a look at them in terms of how big they are. If we want to determine whether they're cancerous or not, or malignant, then a needle biopsy can be done. So the ultrasound machine will be held on the neck, and a needle will be inserted into the thyroid nodule, and a sample will be taken um, to be assessed in pathology for thyroid cancer. But the vast majority of them are just benign nodules. They're not malignant. Okay. Now, some benign nodules can actually produce thyroid hormone. Okay, so this could be a cause of hyperthyroidism. So if you have an active um, thyroid nodule that's producing T4, then you can become hyperthyroid from a thyroid nodule. Okay, but as I said, most of them are benign and not secreting thyroid hormone. What about thyroid cancer? Again, more common in women, much less common than benign thyroid nodules, but sometimes we'll pick up a thyroid cancer when a thyroid nodule is biopsied. Okay, the vast majority of them are relatively slow-growing cancers. Some of them can be more aggressive. And how are they treated? Well, typically with a thyroidectomy, so removal of the thyroid gland, and sometimes radiation to the area. That's the most common way that we treat thyroid cancers, with surgery plus or minus radiation. Okay, so a malignant thyroid nodule. So thyroid nodules, especially when we just palpate the thyroid gland in the neck, if we were to feel a thyroid nodule, chances are that it's going to be benign. Okay, and typically we'll send off blood tests to check the, the thyroid hormone levels in the bloodstream, and we'll do a TSH. After that, we'll do an ultrasound to look at the thyroid nodule. Okay. Now, thyroid nodules, malignant ones, are typically in either young patients, and remember, this is more common in females, young patients, or in the older category. So more of the extreme, so less than 20, over 70. And often there's been some kind of a history of neck radiation. So they had, say, Hodgkin's lymphoma of the neck, and they had to receive radiation therapy. Well, that radiation harmed the thyroid gland, and it predisposed it to forming thyroid cancer later in life. Okay? And typically when we feel a malignant nodule anywhere in the body, not just the thyroid, but if we're talking about the thyroid nodules, they're hard, they feel like rock. They're firm, and they're not mobile at all. They're fixed to the tissue beside them. Okay? So when we feel a really stone hard, immobile nodule, we would be more concerned. And if we were to feel lymph nodes adjacent to the thyroid gland that were also firm and hard, that would be more concerning for a malignant thyroid nodule. Okay, so just a bit more on thyroid nodules. So how do we really look into them when we feel one in the neck? Well, we'll put the ultrasound machine on the thyroid gland, and typically a biopsy is taken of the nodule and sent to pathology to see if it's benign or malignant. Okay. We can also use a scan called a technetium scan. Wouldn't worry too much about it. All it is it's you receive an injection of a radioactive medication that goes to the thyroid gland. And if you have a nodule that's producing large amounts of thyroxine, we call that a hot nodule. If the nodule looks like it's secreting normal amounts of thyroid hormone on the scan, we'll just call that a warm nodule. And then a cold nodule is one that's just not producing any thyroxine, and we know that because on the scan the nodule didn't take up any of the radioactive isotope into it, and we call that a cold nodule. And some of those can be malignant. But I'm going to tell you, if we feel a thyroid nodule, typically we're going to get an ultrasound and do a needle biopsy to really make sure that it's not cancerous. Okay, so let's talk about the parathyroid glands, which are four little glands on the back side of the thyroid hormone, so the posterior side. So there's two pairs of them, right? And they are responsible for controlling serum calcium levels, right? And calcium in the serum is very important for contractions of muscles. It's involved in the nervous system. There's a lot of roles for calcium. And in the past, I know we've discussed hypocalcemia and hypercalcemia. Well, the parathyroid glands make sure that serum calcium levels are not getting too high or too low. Okay, so let's talk about hyperparathyroidism. So this will lead to hypercalcemia. And what's the cause of hyperparathyroidism? Well, commonly it's caused by a parathyroid adenoma. So a benign tumor of one of the parathyroid glands that produces too much parathyroid hormone into the bloodstream. Okay, that's going to lead to, at the bone level, it's going to cause breakdown of bone. So calcium and phosphate are released from the bone when parathyroid hormone stimulates them. Okay, and that will raise serum calcium. Okay, the parathyroid hormone usually works at the kidneys as well, and it helps with reabsorption of calcium before the fluid becomes urine. So there's reabsorption of calcium in the kidneys, again, to elevate serum calcium levels, right? Because the whole purpose of parathyroid hormone is to elevate serum calcium and maintain normal levels. So when it becomes excessive, all of these effects are going to be magnified. So too much calcium breakdown in the bones, too much calcium reabsorption in the gastrointestinal tract, too much calcium reabsorption in the urine. Now, parathyroid hormone also activates vitamin D in the kidney. So when we have vitamin D from our skin in the setting of UV light, that's inactive vitamin D. It has to be activated by the kidney. Okay? So parathyroid hormone assists in that by helping activate vitamin D in the kidney, and it increases vitamin D activation. That will cause the vitamin D to absorb more calcium in the gastrointestinal tract, right? So we have three avenues where calcium is becoming higher in the bloodstream because of the parathyroid hormone. The bone breakdown, the reabsorption in the kidneys into the bloodstream, and activation of vitamin D in the kidney leads to increased absorption of calcium in the gastrointestinal tract. All of that will result in hypercalcemia if there's too much parathyroid hormone. Okay? Now, this effect is counterbalanced by a hormone that's produced by the thyroid gland called calcitonin. So calcitonin will stop calcium release from the bones. Okay? So it's a counter hormone to the parathyroid hormone. So really the most common cause of hyperparathyroidism, assuming all else is normal in the body, is a parathyroid adenoma. Okay. What's another cause of hyperparathyroidism? Well, what about renal failure? So in renal failure, you have reduced activation of vitamin D, okay, because the kidneys aren't working, they can't activate vitamin D. That causes decreased absorption of calcium in the gastrointestinal tract. So now you have low calcium in your serum because the vitamin D couldn't absorb it, and it's going to turn on the parathyroids to secrete more parathyroid hormone to get that calcium level back up to normal. So that would be called a secondary hyperparathyroidism from renal failure. Okay. So anyways, I think in for this discussion, we're talking about, we could call a parathyroid adenoma. Well, that's a primary cause of hyperparathyroidism. Renal disease would be a secondary cause of hyperparathyroidism. Okay. So now, what can cause hypoparathyroidism? Well, the most common cause in the past, and likely still presently, but it's pretty uncommon now because surgeons are very careful when they're removing the thyroid gland not to remove the little tiny parathyroid glands. Okay? So you can develop hypoparathyroidism if you have your thyroid gland removed and by accident the parathyroid glands were removed with it. Okay? And that would lead to hypocalcemia. Okay, as a last part, let's just remember some of the symptoms of a high calcium in the serum. So hyperparathyroidism, typically say from an adenoma in the parathyroid gland, leads to hypercalcemia. I try to think of a couple of areas of the body. So high serum calcium can lead to kidney stones, right? You have a high circulating calcium that can cause deposits in the kidney leading to kidney stones. High serum calcium often causes a stomach upset, nausea, and vomiting, and constipation. Okay, so gastrointestinal symptoms with hypercalcemia. Hypercalcemia has brain effects, so it can cause confusion, lethargy, fatigue. Okay, and there's a bit of a mnemonic you can remember for this. So, and there's one more to add to it. So kidney stones. Okay, we spoke about that one. Painful bones. Well, you have calcium that's being broken down by the parathyroid hormone. So painful bones because there's calcium breakdown leading to osteoporosis. Abdominal groans. Okay, so there's that gastrointestinal symptoms. Neurological overtones. Okay, so there's the confusion and the lethargy. Okay, so kidney stones, abdominal groans, painful bones, neurological overtones. Okay. Okay, now if I was to think of low serum calcium, okay, so the parathyroid hormones were accidentally removed during thyroid surgery, and now I'm going to develop hypocalcemia because I don't have parathyroid hormone to reabsorb um, calcium from the kidneys, to break down some bone, um, to elevate serum calcium, and also to help in the activation of vitamin D in the kidneys so I won't get absorption from the gastrointestinal tract, leading to hypocalcemia. Okay, so I typically think of neurological symptoms when I'm thinking of hypocalcemia. So I'm thinking of tingling fingers, so paresthesias, which is tingling fingers or tingling toes, okay? Muscle spasms. So the nerves to the muscles have become really twitchy because of the low calcium, and so you're getting muscle spasms. Muscle cramps, again, because of the low calcium. It can lead to tetany, meaning the muscles are continually being contracted, okay? You can get numbness around your mouth, okay? So numbness to the fingers, numbness around your mouth, and finally, as the calcium level drops further and further, it can lead to seizures and coma, okay? Okay, so just a bit more detail on hypoparathyroidism. This is definitely a rare condition, right? So you have four little parathyroid glands, so two pairs that live behind the thyroid gland, right? So the chances of being hypoparathyroid are really, really small because you have these four little button-like glands that live on the back side of the thyroid gland. Okay, so what would be the most common cause of hypoparathyroidism? Well, they were removed during thyroid surgery by mistake. Okay, that would be the number one cause. And what happens when you remove all four parathyroid glands? Well, you're going to end up with hypocalcemia because the parathyroid gland is responsible for maintaining normal calcium levels in the serum. Okay, and it does that by secreting parathyroid hormone that activates vitamin D in the kidney. The active vitamin D is able to absorb calcium in the gastrointestinal tract, so it elevates serum calcium that way. Parathyroid hormone can also reabsorb calcium from the renal tubules back into the bloodstream, so it keeps calcium levels high that way. And parathyroid hormone also works on the bones, and it can help with breakdown of calcium phosphate, which is the bone matrix, and that's also going to elevate serum calcium. So when you're lacking your parathyroids, you're lacking all of those functions, and you're going to develop hypocalcemia. Okay? And hypocalcemia is usually a condition where the nervous system is very irritable. So think of irritable nerves in hypocalcemia. So Trousseau sign, Tavostek sign, we've gone over those before. But look at the other one. Muscle cramps, why? Because the nerves to the muscles are irritable. Tetany, which is severe muscle spasms, again, it's because of the irritable nerves to the muscles. And finally, seizures. Well, seizures are really from irritable nerves, right? That are then stimulating the muscles. Okay, so I think of an overactive nervous system when I think of hypocalcemia. How do we reverse hypoparathyroidism? Well, we can replace it with parathyroid hormone, and we can provide calcium supplements to elevate serum calcium. Okay, so the opposite now, hyperparathyroidism. Well, that's excessive secretion of parathyroid hormone. What's the most common cause? A parathyroid adenoma. So a non-malignant tumor on the parathyroid gland that leads to excessive parathyroid hormone production. Okay? So, what's that going to cause? Well, that's going to lead to elevated PTH and elevated serum calcium because you're activating more vitamin D in the kidney, which is going to reabsorb more calcium from the gastrointestinal tract. The PTH can also reabsorb calcium from the renal tubules, and it's going to break down more calcium from the bones, right? And which is going to elevate serum calcium, right? So you're going to be left with hypercalcemia. So primary hyperparathyroidism is because of the parathyroid adenoma. Secondary hyperparathyroidism is something else in the body is making the parathyroid glands secrete excessive PTH. So it's the same idea as any other gland when we're talking about primary or secondary. Okay? So any disorder that causes the parathyroid gland to secrete more parathyroid hormone that's not part of the parathyroid gland as the cause, we'll call secondary. So, for example, renal failure, chronic renal failure. Well, chronic renal failure causes a lack of active vitamin D because that's where vitamin D is activated in the kidneys. So, lack of vitamin D means less absorption of calcium from the gastrointestinal tract. Okay? Low serum calcium is going to activate parathyroid secretion from the parathyroid glands. So here you go. You have secondary hyperparathyroidism due to renal failure because in renal failure you're not making active vitamin D. Okay? That would be one of the more common secondary causes of hyperparathyroidism. Okay, so with hyperparathyroidism, so say we're talking about a parathyroid adenoma that's making too much parathyroid hormone that's leading to high serum calcium levels. What kind of symptoms do we get? Well, let's just think about what calcium is involved in, right? So calcium is involved in muscle contractions. It has some involvement in nerves. Remember when we spoke about low calcium, the nerves became really irritable. But now we're talking about high calcium. So let's look at the muscles. Well, muscle weakness. There's just too much circulating calcium. So now when we look at the brain, poor concentration. It's not irritable anymore. Difficulty concentrating. Kidney stones. Thinning of the bones. Why? Because excessive parathyroid hormone is constantly breaking down the bones. It's breaking down calcium and phosphate from the bones to release into the bloodstream. And finally, pathologic fractures because of the thinning of the bones. Okay? So when I think of high calcium, I think of kidney stones. I think of renal stones. right? I think of painful bones because of the breakdown of the bones and potential for fractures. I think of abdominal um, groans. So often hypercalcemia causes nausea, vomiting, abdominal pain, and I think of psychiatric overtones. So there's that poor concentration. They can get a lot of psychiatric type symptoms from excessive calcium in the bloodstream. Okay, so renal stones, painful bones, abdominal groans, and psychiatric overtones from hypercalcemia. And what can we do about it? Well, typically it's going to be surgery on the parathyroid gland once it's found to have a parathyroid adenoma, then it can be removed. Okay, let's just briefly talk about a little tiny gland that's not part of the hypothalamus or the pituitary. It's not far from the pituitary gland in the brain. And what does the pineal gland do? Well, it produces melatonin, which is a hormone involved in the sleep cycle and regulation of sleep. It's also involved in light to dark cycles that we experience throughout the day, right? So as evening approaches and darkness is supposed to approach, that has an effect on the pineal gland's secretion of melatonin. Okay, so involved in sleeping and regulation of sleep and the phases of the light-dark cycle. Okay, so it's not a really important gland, but there's one thing that I think you should know about it is that when you get a tumor, which again is not very common, of the pineal gland, it can put pressure on brain structures right next to it, and it can block the flow of cerebrospinal fluid. And that's a big deal because when you block the flow and the drainage of cerebrospinal fluid, it can lead to hydrocephalus. So that's what I would know in terms of the pineal gland. What it secretes, what it's responsible for, and the fact that a tumor can lead to cerebrospinal fluid obstruction. And when you have hydrocephalus, okay, what symptoms? Headaches, nausea, vomiting, off balance, seizures, right? So all of those things can occur in the setting of hydrocephalus. Okay.